In 2005, there was a dramatic presentation at ASCO showing that the addition of trastuzumab in an adjuvant fashion to patients who were HER2 amplified and were at high risk of recurrence, the trastuzumab dramatically decreased the rates of recurrence and improved survival. It was one of the most major findings that we've had in the last couple decades. And that study had many patients in it. To get into that study as a HER2 positive patient, you needed to have positive results by IHC and FISH done at the local laboratory where you'd be enrolled at your institution. But a sample was also then sent to the NSABP for further testing. And when the NSABP tested these specimens, they realized about 10% of them at the end of the study were not IHC 3+ and FISH amplified greater than 2.0 FISH result. And looking at those 174 patients, it was seen that they had the same benefit as with the trastuzumab in a reduction of their recurrence and subsequently death. So this became very exciting, and it was unclear if the trastuzumab would benefit patients in this HER2low group. Actually, the HER2low group is 3 times as large as the HER2 positive, HER2 amplified group. So there was enormous potential benefit in this group. A lot of testing was done to make sure that these specimens that the NSABP had collected from these sites were truly not amplified, and a lot of blind testing, in fact, and that confirmed the results. So this very large trial was put together by the NCI and the NSABP, and we enrolled 3,200 patients into that study.
Leads us neatly to the findings.
The finding was quite disappointing in that the addition of trastuzumab to patients who are IHC 1 and 2+ and low FISH scores showed absolutely no benefit whatsoever. The recurrence rates were exactly the same for the two groups. There was no benefit. There was no trends of efficacy seen whatsoever in the particular study. So yes, quite disappointing that we can't extend this benefit to a much larger group of patients, but it does clarify that patients who are locally tested and are HER2low do not benefit from the addition of trastuzumab.
Which then poses the question of why was the response seen in the first group tested back in?
The most likely explanation is the heterogeneity of these tumors. Patients were tested on a certain part of their tumor locally and had a certain result that got them into the trial. And then a block or specimen was sent to the NSABP after they enrolled into the study, and whether the tumor that was sent to the NSABP was really representative of the initial tumor would come into question. We know tumors are very heterogeneous, and that gene expressions can differ quite a bit. There's really an evolution of gene expression within a tumor as it grows. So this is by far, I would say, the most likely explanation for the difference in results. But even a negative result's important because now we know we should not treat those patients. They're not going to benefit.